Welcome to the Integrated Viral Hepatitis Cooperative Agreement National Call for 2103 recipients. My name is Clarissa Sang, and I am the Health Department Support Lead for this cooperative agreement. I'm with the Division of Viral Hepatitis at CDC. The topic of today's call is advancing automatic HCV reflex testing among lab partners. Given the nature of today's topic, we have extended an invitation to our public health lab partners. We have a great program with a packed agenda. Next slide. Before we begin, there are a few housekeeping items. All participants will be muted upon entry to the meeting. If you have a question, please submit it in the Q&A box, including your name and organization, and also the presenter that you have a specific question for. And time permitting, we plan to conduct a Q&A after all presentations have been delivered. Of course, you can also send questions directly to your CDC project officers and regional teams following the meeting. If you have any technical issues, please reach out to Dion. We have a few more updates. NASTED will be hosting a special working group on administrative and other barriers to viral hepatitis program implementation on March 1st from 1 to 2 p.m. Eastern Standard Time. You should have received an email to register, but in case you did not, please email me at the DPH FOA mailbox. And now for CDC updates, we will first have Dr. Nicola Thompson, the surveillance team lead.
Thank you, Clarissa. Happy Tuesday to everyone. So just a few component one surveillance team updates to share. The first is to note that we have a new surveillance officer covering the jurisdictions that are within Region C. So Karen Lewis joined us in January. She has been at CDC for several years and has prior experience working in a state health department. We're thrilled to have her on board. So please look for her name. For those of you that have not yet met her, you will be doing so shortly as part of the individual calls coming up in March. Next slide, please. A general announcement. So thank you to everyone who submitted their year one annual performance reports. Staff within the division are making their way through them and reviewing them. We have identified a couple of instances where we may need to verify a response for a certain question on an APR. So just be aware, there may be folks reaching out to you just to verify responses and make sure that we're capturing all of the information correctly and accurately. Next slide, please. Thank you. So two updates from the surveillance team. So the first is just to let folks know that we had a couple of submissions for the 2020 CSTE meeting coming up in June this year. Two abstracts. One was related to the impact of missing data on injection drug use when the surveillance data is used for epidemiologic analyses. A second abstract was looking at the impact of the change in the acute hepatitis C definition on surveillance data. And then a third item was a proposal for a roundtable session. So this would be on the new viral hepatitis case report form and message mapping guide. All three of these items, if they're not included in the formal CSTE program, will be shared with everyone who's participating in this cooperative agreement, so everyone is able to learn from the work that was done and implement that into their programs if needed. The second item to mention is that we are beginning analyses as a team on the 2020 annual surveillance report. This will include the mortality data for 2020 that was finalized in December of 2021. And also the NNDSS data. I think as many of you are already aware, there has been some severe delay in the process of case reconciliation and closeout of the 2020 data. So we are behind and where we would ordinarily be in the process of creating this report. But we'll be hoping to get this out at some point this year for folks to use for their surveillance practices. Next slide, please. Just a reminder that we have the quality assurance reports going out soon. So they are being prepared right now and we distributed lightly this week. They come from a viral hepatitis mailbox, so please be looking for those. These reports include a data summary and indicators for many of the performance measures that are part of this cooperative agreement. There's items on data completeness and timeliness. I did want to specifically point out that we are missing, there are a lot of key date variables that are used to measure the timeliness of submitting information to CDC. So please take note of the items, the technical notes section, which explain how these various measures are calculated. And if you have questions about the QA report for your jurisdiction, please use that as an opportunity to engage with your surveillance officer who can help walk you through that and provide answers to any questions that you have. And as always, we welcome feedback on the QA reports. Next slide, please. We do have a new viral hepatitis message mapping guide. We anticipate it will be ready by the end of this year for folks to begin onboarding. I did want to specifically point out that there will be a pilot going on that will be led by C-Cells. It's likely to begin in spring of this year. And they are looking for jurisdictions who would be interested in participating in the pilot. So some of the criteria that they use to determine who can participate are jurisdictions that may have participated in pilots before successfully, being willing and able to prioritize pilot participation, not being an NBS user. NBS participates in a separate way in the pilot. And they are looking for people who are first time onboarding to the hepatitis MMG and those that are already on board with the MMG 1.0 and would be looking to switch over. So if you are interested in participating in the pilot or have questions, please use the EDX mailbox to indicate your interest. And next slide. And I'll go through this really quickly, but Clarisse will be mentioning at the end of the call the Endpin viral hepatitis community. And we had a couple of proposals of items that could be worth sharing there based on feedback we've had some jurisdictions. So any tools or resources that have been developed to aid case investigation activities, any viral hepatitis surveillance data summaries or annual reports that you put together could be shared there, or outbreak response plans. The other items that we have been discussing with jurisdictions lately about programs or software that you use for registry management, deduplication, or matching. So if folks are using either custom programs that they've developed themselves, Link Plus, Match Pro, or other items that the Endpin community could be a place to share that item to connect with other health departments. That's it for me today. Thank you.
Thanks so much, Nicola. There is a question for you, so if you can respond to that question, that'd be great. So moving on to Carrie Sapsis, the communication team lead.
Hi, everybody. Thank you so much for having me today. I appreciate it. Glad to join you. I have a couple of communication updates for you today. First, last week, NCIRD released the 2022 adult immunization schedule. The new hepatitis B adult vaccine recommendation does appear in that schedule. Please promote the new schedule to healthcare provider organizations in your state or locality. If you need to access it, it can be found on the CDC site at www.cdc.gov/vaccines. We're also preparing for the release of the MMWR policy note announcing the new hepatitis B adult vaccine recommendation. Release of the MMWR will make that recommendation official, and we anticipate it to come out sometime in early spring. To support promotion of the change, we will be sending emails to all of our partners and awardees, promoting it on social media and updating our web content. We encourage you to please prepare for promotion of the recommendation to healthcare provider organizations in your state or locality. And if you have content on your website about this topic, please start your plan for updating it. May, as all of you know, is Hepatitis Awareness Month, and May 19th is Hepatitis Testing Day. CDC is creating a social media toolkit for partners like you, and we're updating our website to help promote the observances and to provide you with messages and materials. We'll release the resources by mid-April, and we'll make sure to promote them to you through email and your project officers. And last, I'd like to give you an update on our hepatitis C testing campaign for primary care and prenatal care providers. The division will again this year be placing paid advertising to promote the screening recommendation. We haven't yet solidified the dates for the campaign, but we will be reaching out when we do. And we would appreciate your help amplifying the campaign's messages by linking to the campaign website and by promoting it on social media. Thank you so much.
Thank you. If anyone has any questions for Nicola or Carrie, please type them in the Q&A and they can address your questions. The goal of today's meeting is to provide updates on national and local efforts to assess and promote automatic HCV RNA reflex testing. In order to approach this topic holistically, we will have 4 presentations providing both national and local perspectives. Our first presentation will be from Dr. Salim Kamli, who is the chief of the laboratory branch within the Division of Viral Hepatitis at CDC. Dr. Kamli will be providing an update on engagement with commercial laboratories. Our second presentation will be from Dr. Ann Gaynor, who is the Deputy Director of Infectious Disease at the Association of Public Health Laboratories. Dr. Gaynor will be presenting on HCV diagnostics in U.S. public health laboratories, including an update from the 2021 Public Health Lab Viral Hepatitis Survey. Our final 2 presentations will be from our jurisdictional health departments to provide examples of best practices and lessons learned in conducting a laboratory needs assessment toward promoting Hep B and Hep C testing capacity, including automatic HCV reflex testing. Dr. Ann Thomas is with the Oregon Health Authority and is the director of the state's viral hepatitis program. Dr. Thomas will be presenting on Oregon's hepatitis lab survey. Heather Leonardos is the program coordinator for HIV and viral hepatitis surveillance at the Connecticut Department of Public Health. She will be presenting on Connecticut's laboratory survey. So to start things off, Dr. Conley.
Can you hear me okay?
Yes.
Thank you, Clarice. Good afternoon. It's a pleasure to be here with you today and present on what we in the Division of Viral Hepatitis at CDC are doing to promote reflex testing in the field of HCV diagnostics. Next slide, please. Let's first look at when various serologic markers appear in a hepatitis C patient. As you can see here, the primary screening marker of HCV infection, the anti-HCV, becomes detectable after about 11 to 12 weeks after exposure and remains present during acute, chronic, and resolved phases of infection. HCV RNA, on the other hand, can be detected as early as 1 to 2 weeks after exposure. This marker, HCV RNA, is undetectable after about 6 months if the infection resolves, but remains present during the entire chronic phase of infection. Next slide, please. Because testing for HCV RNA is the only way to diagnose current HCV infection, we updated our HCV testing guidelines in 2013, as you all know. The focus of this update was the recommendation of testing of all anti-HCV positive cases for HCV RNA, as you can see on the right side of this slide in purple. Next slide, please. There are several FDA-approved assays for the detection of HCV RNA. And as you can see here, all these assays have excellent performance characteristics with the limit of detection of HCV RNA below 20 international units per mil. Because of the availability of such high performing nucleic acid testing methodologies, it makes perfect sense to automatically perform reflex testing on anti-HCV positive samples for HCV RNA detection. Next slide, please. As you all know, among the many benefits of automatic reflex testing for HCV infection, the most important one is a referral to care of an infected person without having to have a second visit for blood draw and thus avoid its associated costs and delays. Now, are there any technical challenges with performing automatic reflex testing? One of the initial concerns was the potential of contamination if the same sample was first tested for anti-HCV and then for HCV RNA, given the ultra-sensitive nature of the nucleic acid testing methodologies. We at CDC have done lab studies to show that there is no evidence of such contamination with automated serology platforms which use a disposable sample probe system. A single platform using a fixed sample probe where we observed very low level contamination is also being updated with decontamination steps to avoid such contamination issues. Next slide, please. I have listed here some of the steps that we have taken so far for promoting reflex testing for HCV RNA. The guidelines focusing on HCV RNA testing for all anti-HCV positive samples were published in 2013, as I just mentioned. Next, we held our first HCV diagnostic conference in 2017, inviting experts and representatives from academia, clinical, commercial, and public health labs. In our division of viral hepatitis, we have established a work group on viral hepatitis diagnostics, and we are currently focused on exploring all possible ways for improving HCV diagnostics. We recently, APHL organized another HCV diagnostic conference sponsored by CDC, and most of the key questions in this two-day conference focused on how to promote diagnosis of current HCV infection in various settings. Dr. Ian Gaynor from APHL will talk about more in detail later in this session. Next slide, please. Following up on the momentum generated by the October HCV Diagnostic Conference, we are actively engaging with representatives from major commercial and clinical labs, as well as with diagnostic industry. The purpose of these engagements is to promote automatic reflex testing for HCV RNA. And in our interactions with diagnostic industry, we are exploring how we can help with bringing additional diagnostic tools like HCV core antigen and point-of-care HCV RNA test, the GenExpert system, into the United States. These tests, as you know, are already WHO pre-qualified. They are CE marked in Europe and are already widely used outside the United States. Internally, our work group, which meets 1 to 2 times a month, has already met with representatives from a few commercial labs. I highlighted them here on this slide, and we are also meeting with diagnostic industry partners. Another charge for the work group is also to explore revising our current two-step diagnostic algorithm, keeping in mind various slow and high prevalence settings. Stay tuned. Next slide. In summary, we can all agree that a single-step testing that will diagnose current HCV infection is the key to achieving speedy elimination of hepatitis C in the United States as well as globally. In the meantime, the implementation of automatic reflex testing provides a functional single-step approach for diagnosis of current HCV infection. We also believe that FDA's down classification of HCV diagnostics from class 3 to class 2 that was announced recently will facilitate development of additional diagnostic tools. This, coupled with the release of our updated national HCV screening recommendations, provides a unique opportunity to expand HCV diagnostics in the United States in support of same-day test and treat strategies in various settings. We are also planning to initiate a survey instrument which will gather information from all commercial and clinical labs about their ongoing practices of reflex testing and future plans of incorporating assays like HCV core antigen and point-of-care HCV RNA test when they become available in the United States. And we will be happy to share that information with you in the next call. Thank you all for your attention. Happy to answer any questions later on. Thank you. Back to you, Clarice.
I think I'll take it away. Thanks, Salim. So nice to see you all. This is Ann Gaynor from APHL. Next slide. Just a quick overview. I'll go over just who APHL is for those of you that I have not met or worked with. Our survey, HCV testing capacity, as well as testing algorithms. Next slide. Next slide. Oh, there we go. Thank you. So for those of you who are not familiar with APHL, we are the Association of Public Health Laboratories. We are a nonprofit organization that represents our member public health laboratories, which are state and local governmental public health laboratories. And our mission is to shape national global health outcomes by promoting the value and contribution of public health labs, as well as continuously improving public health laboratory system and practice. So while we focus on public health laboratories, we are also very mindful of the broader sort of public health lab system, which involves labs outside of the public health lab space. Next slide. So APHL has done a survey for a number of years that's actually started in 2006 or so around HIV and viral hepatitis testing practices with a focus on hepatitis C. I'm going to focus today's talk on just looking at past surveys from 2014 and 2017. And as Clarice mentioned, this survey is from 2019 and 2020 practices that was fielded in May of 2021. It went out to 106 of our member public health laboratories, which included 59 state and territorial laboratories, which include DC, as well as Puerto Rico and the US affiliated Pacific Islands. We got a response rate, and 47 local public health laboratories, county or city. And we got a response rate of about 77%, which is a total of 82 public health laboratories. If we break down that response rate a little bit further, 82% of our state public health laboratories responded and 73% of our local. And again, we'll look at sort of previous responses from 2014 and 2017 as a comparison. So next slide, please. So we looked at 2019 and 2020 in this particular survey so we could understand COVID impacts. The survey year normally would have been 2020, but given that we knew there was such significant impacts, we also asked on about 2019 testing practices. So because we did that, we were able to ask about some impacts, and what we saw were the categories listed along the left, and then the percentage of public health labs reporting those impacts. So testing volume obviously declined due to clinic and other closures, as well as testing stoppages, resulting in fewer samples being submitted to the public health laboratories. Obviously, due to decreased specimens and challenges with staffing, we also saw, we did see some laboratories had to begin batching and saw some increased turnaround times. We also know that during this time, staff turnover was high and staff were frequently reassigned to assist in the response, resulting in challenges there. There was additional challenges around shortages, as many of you have experienced around mid to late 2020. There was shortages with plastics, leading to test tube pipette tips and test kit shortages, and other test kit or other impacts that have been described include viral load testing and HCV genotyping. So next slide. And just one more click. Sorry, I didn't mean to animate that. So this slide here shows along the bottom are 2014, 2017, and 2019, 2020 testing practices. The dark teal is HCV testing, and then and crosshatch is HIV for reference. And so what we see here is the number of public, or the percentage of public health laboratories reporting performing testing for either HCV or HIV testing over time. There's a little bit of a wiggle there between 2014 and 2017 before it goes back up to 62% in 2019, 2020. So relatively stable number of labs performing HCV testing overall. We actually see a decrease in HIV testing just as a reference. But the one thing I wanted to note is that Most of the testing for HIV and HCV can be performed on the exact same platforms, whether that's a serologic assay or a molecular assay. And so there's some capacity in the public health lab system that's not being utilized. So if you look at 2019, 2020, we have 62% of labs performing HCV testing, but 80% of those exact same labs are performing HIV, and those theoretically could all also be performing HCV. So we have a little bit of room in the system to increase HCV testing. Next slide. This slide looks at the average number of FTEs that are trained and or routinely assigned to perform testing. So along the bottom, from left to right, we have local public health laboratories, middle is state public health laboratories, and on the right is sort of the combined. In teal, we have those that are currently trained to perform HCV testing, and on the right, in the orange bars, are those routinely assigned. So again, there's capacity in the public health laboratories. There's more folks that are trained than are actually performing testing, which is great news. So if there was a surge or need to sort of increase testing, we do have capacity. Most labs have done cross-training to ensure that. So again, another place that there's some capacity in the system. Next slide. So as Celine mentioned, for HCV testing, the algorithm dictates that you need to do HCV antibody testing, and if positive, reflex to HCV RNA. So this is looking at public health laboratories performing both HCV RNA and antibody testing. So again, along the bottom, 2014 on the left to 2019, 2020 on the right, the purple bars are HCV antibody testing performed in public health laboratories, and in the green is HCV RNA. So we have pretty stable, pretty high amounts of labs that are performing HCV testing. They're performing HCV antibody testing. And we've seen an increase over time of labs performing HCV RNA testing. We actually did a push in 2018 to increase HCV RNA capacity and expansion in public health laboratories. So excited to see that growth, but again, more room for improvement with that sort of gap between the 94% performing HCV antibody and 58% performing HCV RNA. Next slide, please. So another question that we ask on this survey is about their actual testing algorithms, and this gets to the point of today's webinar. So on the left-hand side, there are 25 public health laboratories that perform both HCV antibody and HCV RNA testing in-house. And then we ask them which algorithm they sort of follow, or sort of the details of their algorithm, I guess. And so 68% of those laboratories will perform HCV RNA on an automatic reflex. So any HCV antibody positive sample would automatically be tested for HCV RNA using the exact same sample. So that's pretty good. It's almost 70%, but again, there's room for growth. So that means there's 30% or so of laboratories that are not doing that automatic reflex. And I'll talk about why not in just a moment. On the right-hand side are public health laboratories performing HCV antibody testing, only performing HCV antibody testing in-house. They're not performing HCV RNA testing in-house. But about a third of those are still automatically referring HCV antibody positive samples for HCV RNA using the same sample. So again, a room for growth for sure, and an area that we would like to focus on, but we do have about a third that are automatically reflexing, even if they're not performing that testing in-house. So when we asked so what the other reasons were, some labs are requesting an additional sample for HCV RNA, and that goes back to sort of Salim's comments earlier. There's this concern about cross-contamination. Some of that's from the actual instrumentation, but some of it's just from handling of specimens. You're always going to increase your potential for cross-contamination if you're opening and closing tubes more often. Some of them will perform HCV RNA sample, HCV RNA testing using the same sample, but only upon request. So there's a sort of additional step that we need to help them remove to optimize testing. And then other circumstances that they used. So those are things that we are going to focus on in the coming months and years as well, and is an area for growth for our public health laboratories. In closing, before we go to the next slide, I just want to say I didn't include a slide on this, and I do apologize, but APHL, I mentioned we offered an RFP to help expand HCV RNA testing back in 2018. The biggest challenge that public health laboratories face is paying for HCV RNA testing. And so we did stand up, in addition to that RFP that we did sort of as a one-time funding, we did stand up an HCV NAT reference center. So laboratories who are performing HCV antibody only testing in-house but need access to HCV RNA testing, there is now a reference center that APHL operates and has a number of submitters if they're a low volume laboratory and don't have a lot of samples themselves, that they're able to submit to that reference center. So next slide. These are some additional viral hepatitis testing resources that are beyond HCV as well as HCV. These are all available on APHL's website at aphl.org/VH. For any of you who are on the call today who are interested in the reference center, please feel free to reach out. My email address is there, and my apologies for not including a specific slide on that. But we look forward to working with you all and supporting you all. And I don't have any other updates from the meeting that Salim mentioned, but we are hopefully getting a report out soon. And there is also information on that meeting, including recording and slides, also again at aphl.org/viral hepatitis. So with that, I thank you all, and I will take it to the next speaker.
Thank you. Thank you for inviting me. Can we go ahead and advance to my next slide? So basically the goal of our laboratory survey is to contact all the labs known to be reporting cases to determine whether they conduct reflex testing on that initial antibody positive specimen. Additionally, we want to make sure we aren't missing anybody. So we're also contacting compliant labs, which are those that are licensed to conduct moderate to high complexity testing in Oregon, to find out if they are conducting hepatitis testing that we don't know about. And so of course we want to determine the percentage of labs that have a policy of reflex testing and what the barriers are for labs that don't do the reflex testing. And we're inquiring about their reporting methods and barriers to reporting. And then lastly, we don't have a requirement or administrative rule that requires negative HCV RNA results to be reported, but I'd like to move in that direction. So we're hoping to use this opportunity while we're contacting people to recruit for a pilot project of labs to start reporting to us. Next slide. So far, starting out with what we do know of the labs that we know have been sending us positive Hep lab reports. We identified, looking at our data from the last 2 years, we identified 55 labs that have reported cases. And the interesting thing is that our 5 biggest health systems are not kind of the largest sector of reporters. They typically cover labs that are in the Portland, or cover clinics that are in the Portland metro area. But for the rest of the state, in more rural areas, they tend to rely on the big out-of-state reference labs, which for us are Mayo, Quest, Arup, and was it LabCorp. And then there's Interpath, which is one in Eastern Oregon that's fairly large, as you can see. So far, we have sent out an online survey by SurveyMonkey by email twice. And we're going to do one more round of emails this week, and then start calling people. So far, I think we've only gotten 9 responses, and only 6 actually responded. Actually, why don't we go to the next slide here. In terms of the other labs that we know that potentially have the capacity to do hepatitis testing, we looked up this list on this website and identified 258 compliant labs, but many were either already known to us or they were dermatology clinics. And after talking to 1 or 2 of them, they do not seem to do hepatitis testing. So we whittled down that list to 120 labs. And at this point, we've contacted about half. I have identified 4 additional labs that do their own hepatitis testing in-house, but didn't report a case in the last 2 years. So they will be sent the full survey, and also we'll be sharing our reporting guidelines and working with them to report cases to us. Next slide, please. So this is just the kind of the wording of on our survey that's being sent out. So we ask for specimens that have anti-Hep C screening test positive results. Please indicate on what basis the reflex testing is performed. So we're collecting our information on whether it's automatic, or whether it's only based on a physician request, or whether they never do it, or if there are any other categories. And then we have a list of kind of options for what some of the barriers are either some type of laboratory testing policy or payer issues. And as I started to go into before, we've only received 6 responses for people who answered this question, but 4 of them did conduct reflex testing. Unfortunately, only one of those is one of, I think it was Mayo. Only of the big 4 out-of-state labs, only one has responded so far, but we're really interested in seeing how the big commercial labs do on this. Next slide. And then on the reporting practices, we ask whether they report either to our agency at the state or the local public health authority by electronic lab reporting. And Oregon has a pretty strong tradition of ELR. I mean, it's been up and in place for 20 years, and we typically receive 90% of our case reports by ELR. But there still are a few smaller places that report by phone or fax. And then we'll ask about the barriers to reporting. And then the interesting thing that has come up is that there is actually a third way that clinicians or labs could report to us. And we actually have, just online, we have an electronic case report. If a doc wants to tell us about a case of measles or acute hepatitis, they can just submit the information online, and it's not used that much. But what we have found is that there are some community-based agencies that are doing rapid HCV tests, not going through a laboratory, and just rapid finger stick tests. And many of them use this this electronic case reports online capacity, and that's one thing that we haven't really taken into account or looked into, and we're starting to find some discrepancies between the number of tests that some of them are reported, are participating in studies, and we know how many they've conducted and how many are positive, and the results aren't matching up with what's getting reported to us. So if you have any kind of small or kind of non-standard reporting mechanisms, I would recommend you kind of look into that. And I think that's all I have for my slides. So I look forward to your questions at the end. Thanks.
Okay, hi everybody. I hope you can hear me. I'm Heather Leonardos. I'm the HIV and Viral Hepatitis Surveillance Program Coordinator, and I'm going to talk to you today about a clinical lab survey that we conduct in the surveillance program. I'm actually really glad that I'm going last today, because listening to Dr. Gaynor and Dr. Thomas's presentations, there's a lot of crossover, and I can kind of show examples of some of the points that they made in their presentation. Next slide. Oh, thank you for the note. I have a little slidey thing over. Sorry about that. Okay, so just a quick overview of what we're going to talk about today to give you some context. We'll talk about our agency and program organization, touch upon the surveillance activities where we felt we could leverage this work, and then dive into the survey a little bit, and then what are we going to do with the data in next steps. Next. So this is our entire DPH org chart. I just wanted to highlight here the blue circled boxes. Our resources for 2103 are kind of sprinkled around. We have hepatitis B surveillance occurring in the immunizations program, hepatitis A surveillance occurring in the epidemiology and emerging infections program, and then hepatitis C prevention and surveillance occurring in the TB, HIV, STD, and viral hepatitis section. Next slide. So drilling down a bit just on our section I just mentioned, you could see over the left. So we already co-PI the HIV surveillance and prevention programs for health departments, PS 18-1802 grant. So we thought this would be a good fit for viral hepatitis 2103 as well. And that's how we approach our application. Next. And you could see that we allocated the 2103 resources and surveillance with 1 FTE, and then 3 part-time allocations in prevention, and there is quite a large in-kind contribution to 2103 at Connecticut DPH. Next. Okay, so as we were looking at the grant guidance, these sort of jumped out at us in surveillance because we knew that we could easily sort of offer an assist to the prevention colleagues with addressing some of these things. We had been sort of towing the line in the absence of funding at DPH for Hep C surveillance for quite a few years. And we could provide A and B. We were happy to include the assessment in an HIV clinical laboratory survey that we already had in progress. So next. So just looking at the HIV side of the 1802 requirements, under strategy 1 lives the majority of the surveillance activities, and there are 18 in all. Those are mainly just the routine day-to-day things that we're expected to conduct the work, but it includes to implement and maintain activities to support complete laboratory reporting. And there's many ways that we go about doing that. There's volume reports, matching programs, QA programs, deduplication. So there's many things that the laboratory goes through in just the routine processing of the data. Next. And before we jump into the survey, I just wanted to show you guys some of the data. This is just the antibody positive test results received by the department, comparing 3 years pre-pandemic and mid-pandemic, I guess. Just the first 6 months, so we could just sort of zero in on that early spring dip where the pandemic really had a significant impact on what we're receiving for significant findings at the department. And interestingly, what I found very interesting about this data, and I want to shout out to our Hep C Epi Dustin for pulling this together for me, for you guys today, was the volume in general. This is a significantly higher volume than what we're used to seeing with HIV, and also the recovery. So if you're looking at the baseline, just using 2019 as just a baseline data, and then you see that significant drop in April 2020, which is what was expected and probably everyone is familiar with on the surveillance end anyway. But then, I was really surprised by the 2021 data, and it's very encouraging. And I can tell you that in our HIV volume reports, we're not seeing that robust of a recovery quite yet. So you may want to try to figure out why that is. But okay, next slide. So for the laboratory survey, there are a few things, reasons why we conduct this in HIV. We do it periodically. I would say annually. Once we start reaching out to contacts who are no longer the person that we thought we would reach, or there were a lot of updates in the technology used for testing, or whatever changes may happen, we know that it's time to do it again, get a hold of it. So we start by looking at, some template data, some good examples of lab surveys. We start with the one we had used in the past, and we may adjust questions based on what testing technologies are now in the market or whatever else has happened. But we really want to make sure that we have a good contact list for follow-up, just for reporting lapses, be it ELR or something much more granular, like if you're reviewing a chart and a result in the chart that you don't have in the data system, we would typically call the lab and ask them to fax that over. We have a really broad array of reporting modes currently. There's a lot of ELR, but we have a few health systems in the pipeline that we're just about to start testing when the pandemic kind of landed in our informatics team's lap. And our resources were just completely consumed with that. But I believe they're starting to get back to the onboarding work. So the most important thing here is to understand the relationships between primary and reference laboratories. And the reason why is because that break is such a barrier to care. In HIV, algorithm is quite complex, and it can involve up to 3 different tests. And we have at all times, a revolving total of about 100 incomplete algorithms that we have to follow up on and hunt down that RNA. When you have discordant, antibody and confirmation tests, you then have to confirm with RNA, and that would actually result as an acute case. So we really, this kind of drives us crazy, who's going to be reporting, what are the responsibilities there, and they do change sometimes. So it's good to understand and know, okay, if this hospital is drawing, but they only have a send out department and they're going to send to maybe their parent hospital, their health system to do the first test, and then they're going to refer out, the confirmation or the RNA. So it's different for everybody. It's really hard to wrangle it all together, but we are expected to do that. And I have the link there down at the bottom if anyone wants to the link's still live because we still have a few stragglers that we're hoping to round up. But if anyone would like to check out the survey, they can just go to that link and see. Next slide. So this is just the HCV add-on. It was fairly simple, wasn't anywhere near as comprehensive as Dr. Thomas's survey, but we just simply asked, does your laboratory just, baseline assessment, are you testing for HCV antibody, yes or no? If no, what reference lab are you using? And then if the antibody test is positive, are you reflexing to HCV RNA testing? Then down at the bottom, we include a little PSA to explain that this is a more efficient and patient-centered approach, which is absolutely true. Next slide. So just the results here, 77% reported that they did test for antibody, 1% no, and 20% reported no, but they send out to reference lab. Next. And then for labs that were reflexing to HCV RNA testing, pretty encouraging, 62%, but there's still 11 labs that could use some follow-up, and we'll get to that in a second. Next. So for next steps, we were able to help our colleagues in prevention with some of these requirements. And then, there's all kinds of options for what that feedback to the labs who are not doing reflex testing could look like. And that is something that we can discuss internally. And then I feel like this would also be really good data as a gap in services that can be included in the elimination plan. Next. Next slide, please. Next slide, please. Oh, thanks. Okay. All right. So just in summary, some key takeaways are, if you have partners, if you're sort of organized like us and are doing viral hepatitis surveillance along with HIV, you can talk to your colleagues to see if you can leverage their survey, if it's like planned or in progress. And if they are not doing it, then perhaps another surveillance program at your department is. It's not just limited to HIV and viral hepatitis. It's something that's actually pretty common. And if that's not possible, your HIV surveillance people will definitely have a contact list that you could see if they'll share with you. And that's a great starting point, because as I was thinking about this, I'm like, if you're only going to do the HCV requirement there, then maybe you don't even need to do a whole SurveyMonkey survey. You could just get that contact list and make create a nice email and intro and kind of explain the purpose, and then just put those questions directly in the email to sort of do your assessment. But what's nice about using SurveyMonkey or the like, or online tools, is that it's a really easy to share the survey. It's easy to collect the data back. You can analyze the data right in there, and it becomes like a little mini database that you can refer back to see what the answers were for individual labs. We do export it as well, but I like the history that we can access, going forward. Next slide. And this is, I just wanted to shout out to our small but mighty viral hepatitis Connecticut team. And that was a phrase coined by our program director in prevention, Marianne Buccelli, and her team is Benicia Heron, who's our newly minted viral hepatitis prevention coordinator, and our beloved nurse consultant, Deb Goslin, who's officially retired, but returns annually to help out part-time. And then on the surveillance side on the left, it's myself, Suzanne, and the data manager, Dustin, the HCV epidemiologist in the HIV and viral hepatitis surveillance program, and Alessandra is the hepatitis A surveillance epidemiologist in Epi and emerging infections program, And last but certainly not least, Claudia in the immunizations program, who conducts hepatitis B surveillance epidemiology. And that's it. If anybody has any questions or needs the link to the survey directly, you can type it in. Okay. All right. I will drop the link in the chat. So if anyone wants to check it out, they are welcome to go look. But thanks a lot for having me today. I appreciate it.
Thanks so much to all our presenters. Before we begin the Q&A, I want to emphasize utilizing the Endpin Integrated Viral Hepatitis Community. It includes jurisdictional resources, including resources related to today's presentation, such as lab surveys and health systems assessments. It also has a collaborative document where jurisdictions can share information obtained on Hep B and Hep C testing practices and point of contacts from national commercial labs. So far, the collaborative document includes contacts from LabCorp. And if you have questions about registering to the Endpin community, you can email me at dbh_FOA@cdc.gov. And also this recording will be posted in the Endpin community, so another reason to join. And now we will be addressing questions from the Q&A box. And you can also raise your hand if you have a question for any of our 4 speakers.
Great. The first question in the box is from Rachel McLean, and I believe it's for Dr. Comley. Can you clarify what it was that's being updated to reduce the risk of contamination with fixed probes, the APHL guidelines, ?
So the platform that uses the fixed probe, the probe goes into the sample and then the reagents and the next samples, thereby resulting in low-level contamination. What we have heard from the vendor that they are installing a heat inactivation step in the instrument that will decontaminate the probe, thereby eliminating any chances of cross-contamination. And what we did internally at CDC, we used all the platforms that I listed from all the major manufacturers. We interspersed high-level HIV RNA samples with low-level HIV RNA positive samples, tested all of them for anti-HCV and then HCV RNA. And then we found that the fixed probe systems had no contamination whatsoever. Only one instrument had a very low level contamination. Did that answer your question?
Thank you. One more question for you, Dr. Comley, from Lisa Randall. Do I understand that DPH is serving all clinical labs regarding reflex testing? This is concerning relative to potential overlaps with health department efforts to assess current clinical lab capacity for reflex testing within their respective jurisdictions. Can you please clarify?
Sure. Well, thank you very much, Lisa, for asking that question. I meant to clarify it. No, we do not plan to survey all the labs. This is just the 4 major labs, the ARUP, the Quest, LabCorp, and the Mayo Clinic, and the 2 others. This is not a major survey for all the labs that's planned by, I think, individual jurisdictions. So limited number of questions just to understand what are the plans for automatic reflex testing, and also how do they plan to incorporate HCV core antigen and point of care HCV RNA test once they become available. So it's a very limited survey. Thank you, Lisa.
Okay, the next question comes from Colleen Flanagan. I believe this goes to Dr. Gaynor. When do you plan to survey labs of current HCV testing practices? Will the results be available to states?
Sorry, I missed that one. I got most of them in the chat. So we survey every 3-ish years. So we surveyed on 2017 practices and on 2020 practices. And the actual report will be out hopefully just ahead of the 2022 Advancing Diagnosis for HIV, STI, and Viral Hepatitis Testing Conference at the end of March. So it will be posted on our website when it's done. And Monica will know as well, Colleen.
Great, thank you. The next question is from Danae Schoenborn. I believe this is for you as well, Dr. Gaynor. I think it's important to work with commercial and diagnostic laboratories for HCV reflex testing. However, what about working with insurance companies? From what I've heard, HCV antibody testing is covered under preventative services. Once they conduct HCV reflex testing, it is considered diagnostic and subject to higher costs. This is an issue for underinsured individuals. From what I've heard, the test can be expensive.
So I'm happy to try to answer, but I think anyone else has more experience in this, feel free to jump in. So yes, we do know that there are some issues with reimbursement. My understanding is that CMS has different reimbursement codes for screening versus diagnosis, which can cause a challenge. I am not familiar with that being a specific challenge with the automatic reflex testing. So Salim has mentioned sort of this working with commercial laboratories. We know several of the commercial laboratories are only offering reflex testing. So they have found a way to do it, although I don't know the details of the reimbursement and insurance piece. As part of the meeting Salim mentioned, we are working on recommendations, including looking at some of the reimbursement issues. APHL is not necessarily the best positioned to help with that. So we are looking to help work on that, but we'll need some additional stakeholders. So I don't know if Salim, Heather, Ann have any other comments on testing and reimbursement. It's certainly not an area I'm super familiar with. So if you have any other thoughts.
I think it's a good question, and it makes sense because it's just more expensive. It's a lot, it's like $150. It's roughly 10 times the cost of the antibody test. And I honestly don't know. I'm hoping that our survey will get at that, at least from the laboratory standpoint, if they don't do it just because they don't get reimbursed. And then secondly, after we finish this, our next step is to be meeting with our 5 biggest health plans to look at their policies. And I think we'll get a better sense there. So you'll have to invite me back in a few months.
Yeah, and I will say, so there's also a difference between the actual test cost and the test charge. So antibody testing is cheaper than RNA testing, but the reimbursement rate for RNA testing is quite a bit higher than the reimbursement rate for HCV antibodies. So larger or for-profit commercial entities certainly charge a lot of money for RNA testing as compared to the antibody because they can get a higher reimbursement rate. So just another plug that if you haven't talked to your public health laboratory lately, it might be a good chance to figure out a more cost-effective way. And it may not be, but it's always good to chat with them because they might be able to do it more cost-effectively than a commercial laboratory.
We have one last question if we have time, Clarice. It's from Rachel McLean to Dr. Gaynor. To follow up on Colleen's question, can APHL share back with us the APHL HCV testing survey results from our states for the local public health labs in our states?
APHL's data sharing policy is that we only share data in aggregate. But Rachel, if there are specific issues or concerns, feel free to reach out and I'm happy to chat further. But we can't provide data that's identified by jurisdiction.
Great, that takes care of the questions in the chat. Clarissa, I'll turn it back over to you.
I just wanted to thank you all. Thank you to our speakers for some very wonderful and informative presentations. Thank you also, Sajada, for moderating the Q&A and also for Nicola and Carrie for their updates. We hope that this session was helpful and you have gained some insight and resources to how you can work together to advance automatic HCV reflex testing today. So again, thank you so much to all of our wonderful speakers and we'll talk to you then soon.